we'll move on to our next speaker. We're really pleased to have Dr. Biff Palmer, who's a professor of medicine at UT Southwestern Medical Center in Dallas. He received his MD at UT Southwestern, then completed residency and a research fellowship at Walter Reed, clinical nephrology fellowship back at UT Southwestern. And many of us know prolific author, outstanding teacher, and maybe to round out his credentials that might be especially compelling to us in the Pacific Northwest, also an experienced mountaineer. And as I understand it, a few forays along the mountain just down the road from us. So welcome back, if virtually, to Seattle, Dr. Palmer, and I'm so happy to have you.
Well, thank you very much, Dr. Butler, and it's a real pleasure to be and an honor to be able to speak to your division. And so again, thank you so much for the opportunity. I certainly wish I could be there in person because, as you suggest, I love coming to your area. I've actually had an opportunity to summit Mount Rainier 2 times, but who's counting? But anyway, so I'm going to talk to you a little bit about new insights into the pathophysiology and treatment of hyperkalemia. So let me begin just by kind of overviewing some normal K homeostasis. Remember that in a typical 70 kilogram individual, we have roughly 3,500 milliequivalents of total body potassium. The majority of that resides in the extracellular or in the intracellular space, with only a small amount in the extracellular space. And it's this large inward to outward gradient that determines the cell voltage. And this is why disturbances in plasma potassium homeostasis really give rise to manifestations in excitable tissue, things like cardiac tissue and neuromuscular tissue. Just an overview of K homeostasis. If you ingest 100 milliequivalents of potassium a day, the kidney is primarily responsible for excreting that load, but there is a small contribution of the GI tract. And as you well know, as you lose kidney function, the GI tract starts to assume a much greater role. In fact, by the time you reach dialysis, there may be as much as 50% of potassium loss from the body occurs in the colon. And at least anecdotally, people have described people on dialysis, if you undergo a colectomy, you tend to have more problems with hyperkalemia. Now, the kidney's ability to excrete a potassium load is not really all that quick. It's a little bit sluggish. So following K ingestion, we initially shift potassium into the cell to allow several hours for the kidney to reestablish total body K balance. The 2 most important factors that are involved in, from a physiologic standpoint, at least in that K shift, are the release of insulin and beta adrenergic stimulation. So when we eat food, we release insulin, not only to control the plasma glucose, but also to shift that potassium into the cell to allow enough time for the kidney to reestablish balance. The role of beta adrenergic stimulation, I think, is most important, for example, during exercise. Remember, when you exercise, there's actually a lot of potassium that starts to accumulate in the interstitial compartment of exercising muscle. And that actually exerts a vasodilating effect, which is appropriate for the exercising muscle. But obviously, you don't want the amount of potassium accumulating to be excessive. So as we activate autonomic nerves through beta stimulation, that keeps the amount of K that's exiting the cell in check. I think this vasodilating effect of potassium in interstitial muscle likely contributes to the association of total body K depletion and the higher risk, for example, of rhabdomyolysis or skeletal muscle ischemia. So remember, in the kidney, it's freely filtered across the glomerulus, largely reabsorbed in the thick ascending limb. And then the component of K handling that's highly regulated and varies according to need is that component of secretion in the distal part of the tubule. And the primary determinants of that secretion include mineralocorticoid activity, the amount of sodium being delivered to the distal nephron, and flow rates. So the main cell that's involved in K secretion here is the principal cell. You've all seen this before. Again, I'll just point out that mineralocorticoids do a number of things. They increase the density and activity of the NAK ATPase and thereby keep intracellular sodium low. And remember, having an adequate amount of sodium being delivered distally is important because as that sodium's reabsorbed, we create a negative charge. And this is one of the big driving forces for K secretion. The third factor I mentioned beyond mineralocorticoids and sodium delivery is flow rates. So at high flow rates, you augment K secretion both by diluting luminal K concentration and keeping a favorable gradient for secretion. But we also know that at high flow rates, you actually express a second flow-mediated K channel, so-called maxi-K or BK channel. It's thought that there's a cilium on this cell, and as it bends, you increase intracellular calcium, and that may in fact be the signal for the expression of this flow-mediated K channel. Now, let me just point out that the normal kidney actually has a very large capacity to excrete potassium when challenged with a load. And just to kind of illustrate that, I share with you these 5 studies where they took individuals who were on a given potassium diet and then challenged them by markedly increasing their dietary K. And as you see, there's really not much change in the serum potassium concentration. So again, the normal kidney can handle a lot of potassium. How does that come about? Well, based on some older data, we know that high K intake leads to medullary recycling, and as potassium builds up here in the interstitium, it actually exerts an inhibitory effect on salt handling in the thick ascending limb. That would increase flow and sodium delivery to the K secretory sites and contribute again to K loss from the body. There's even some evidence in older data that there may be an inhibitory effect on some proximal sodium reabsorption. But this can't really be the whole story, because when you think about it, the proximal tubule and the thick ascending limb, these are very high transporting segments. And one would really want to know, would you have the fidelity required that with a high K intake, you would inhibit just the right amount of salt to enhance distal K secretion, but it not be excessive and make you prone to volume depletion? In other words, would high K intake suddenly cause volume contraction? Well, I think what more recent data has really illustrated is that the ability of high K intake to cause augmented K secretion may be actually very regionalized to the distal nephron itself. And I just summarized a large body of literature here where, remember, in the distal tubule, it's typically divided into this initial portion called DCT1, where we have the thiazide-sensitive sodium chloride co-transporter. And then you start to go into the latter portions of the DCT and extending into the collecting duct, where we develop aldosterone sensitivity. And some of the current thinking suggests that with a high K intake, as extracellular K concentration rises, albeit within the normal range, you actually depolarize this initial segment, the DCT1. In other words, if extracellular K is slightly higher now, this would exert a depolarizing effect such that the cell interior would be less negative. Well, with a less negative cell interior, there would be less extrusion of chloride through these chloride channels. And the net effect is that chloride concentration would slightly rise. And what is known is that these with no lysine kinases, particularly this WNK4, is particularly sensitive to changes in chloride concentration. And with its downstream mediators, you get dephosphorylation of that thiazide-sensitive sodium chloride co-transporter, and therefore an inhibitory effect on salt transport. Now, with higher sodium being delivered to the downstream mineralocorticoid-sensitive portions of the nephron, we're able to facilitate electrogenic K secretion. And with the higher flows, we can actually facilitate K secretion through the maxi-K channel. So the idea here is that high K intake in a very regionalized way can augment K excretion through this thiazide-like effect. And it's well known, as you know, that high K intake actually exerts a diuretic effect. Well, there's also data that with high potassium intake, we can initiate kidney potassium secretion as early as potassium entering into the GI tract. And that is that there seems to be evidence of a gastric kidney signaling that even in the absence of a change in mineralocorticoid activity or even a change in the plasma potassium, potassium entry into the stomach can lead to that dephosphorylating effect, at least in rodent models, of this thiazide-sensitive sodium chloride co-transporter, and again initiate K secretion. And perhaps a nice clinical study that illustrates the evidence of this gastric-kidney communication is shown here, where you take otherwise normal individuals and put them on an aldosterone blocker to try to remove the effects of aldo, and then feed them a meal enriched in potassium. And what you see is, despite really no change in the serum potassium concentration, there's really within a very rapid time increases in kidney K excretion, again, in the setting of having mineralocorticoid activity blocked. So again, just to summarize, high K intake can lead to rapid increases in kidney K excretion. We talked about this regionalized mechanism, the evidence of this gastric kidney signaling process. I also remind the audience that there is a circadian pattern of K secretion such that it's higher during the daytime hours, less so in the night, perhaps reflecting conservation or through evolution of when we typically eat meals. I would just add, one popular theory is that this robust ability to get rid of potassium likely reflects what our ancestors probably ate. It's estimated that our Paleolithic ancestors may have eaten as much as 15,000 milligrams or fourfold higher than what we eat today of potassium. And so that the design of the kidney was actually to handle a K load. But with over time, as you know, our K intakes have progressively fallen, our dietary sodiums have gone up. And so that in essence, in today's world, we have a mismatch between what we present to the kidney and what it was actually designed to do. And maybe that mismatch is linked to a lot of cardiovascular complications, things like hypertension, kidney stones, and the like. Well, how is K homeostasis altered in our chronic kidney disease patients? Well, I wanted to go back to an older study that I think is very illustrative. As you well know, if you read most textbooks, it says that you really shouldn't develop hyperkalemia until you get to less than GFRs of less than around 20 mLs per minute because of adaptations that occur in the remaining nephrons. And what supports that is this older study where these investigators took dogs and left them with one intact kidney and surgically removed the majority of the contralateral kidney. In other words, they just had a remnant. And what they noted was that the majority of the potassium excretion from the body was occurring through the intact kidney with only a small amount from the remnant. And at baseline, they have a normal plasma potassium. Now, the experiment is in that setting, if you take out now the intact kidney, leaving the animal only with a remnant, notice that within less than 24 hours, there's a fourfold increase in urinary potassium secretion with really no change in the plasma potassium. And by 7 days, this has now gone up sixfold, again, keeping plasma potassium largely unaltered. Histologically, these remaining nephrons develop increased basolateral infolding. There's increased expression of the sodium potassium ATPase. The nephrons are undergoing an osmotic diuresis, all of which presumably helps keep the plasma potassium well preserved despite this massive loss of kidney mass. Now, to be sure, if you challenge such an individual or animal with a K load, there's a much larger increase, and the time that it takes to normalize takes much longer as compared to the normal setting. But the point is, through adaptation, you're able to keep plasma potassium fairly well controlled despite substantial losses of kidney function. Now, the other process, of course, that's helping K stay in a well-accepted range is increased colonic K excretion. Again, I would just remind you that here in this model of a colonocyte, the main route for potassium secretion is through these BK channels. And there does seem to be increased expression of these BK channels with loss of kidney function. Now, despite the fact that we read that you shouldn't get hyperkalemia until your GFR is less than 20, in clinical practice, we typically see hyperkalemia at much earlier stages of chronic kidney disease. And whenever that's the case, you always have to ask if there's one of three things superimposed on that loss of kidney function. In other words, one thing that can cause an early onset hyperkalemia is a primary decrease in distal sodium delivery. So for example, decompensated heart failure, acute glomerulonephritis with very low distal sodium delivery causes rapid onset in hyperkalemia. Anything that would decrease mineralocorticoid activity would lead to early onset abnormal potassium, as well as disease states that primarily target the collecting duct, as with interstitial kidney disease, for example. With regards to mineralocorticoid activity disturbances, again, a lot of the medications we use in practice can be a culprit in this setting. Again, remember, whenever I see hyperkalemia, I kind of think, are there any medicines that this patient might be taking that are interfering in the renin-angiotensin system? And so here at the beginning of the system with blockade of renin release from the JG cells, perhaps the most common offender are your NSAIDs. Remember, prostaglandins regulate renin release from the JG cells. Adrenergic nerves influence renin release, so beta blockers can actually cause early onset hyperkalemia by causing hyporeninemia. So the calcineurin inhibitors, really through a variety of means, can cause hyperkalemia. And when you take care of transplant patients, this is always an issue. But one of the things that they can do is suppress renin release. Diabetes is a risk factor, presumably from microvascular disease of the afferent arteriole injuring the JG cells. And even as we age, there's an age-related decline in the ability to make renin, perhaps explaining why hyperkalemia tends to be more common in older individuals. There's one drug that targets the enzymatic activity of plasma renin. That's called aliskiren, not really used that much anymore. ACE inhibitors obviously block the cascade here. The ARBs block the AT1 receptors in the zona glomerulosa, the adrenal gland. And then drugs that impair aldosterone release, things like heparin, again, reversibly interfering in aldosterone biosynthesis, or the azole antifungal ketoconazole. We have the aldosterone receptor blockers, things like spironolactone, eplerenone. This new agent, finerenone, it can cause hyperkalemia, but seems to do so a little bit less commonly, likely because it's a shorter acting agent and doesn't have active metabolites. And then this progestational agent, drospirenone. I mentioned this last one because imagine drospirenone is found in a lot of birth control pills, particularly this one called Yasmin 28. And if you look at the package insert for that product, it says use with caution in people who are on an ACE or an ARB. So imagine that you had a young diabetic woman who you'd like to put on an ACE or an ARB for kidney protection. Perhaps she had some microalbuminuria. But at the same time, you're worried about teratogenicity should she become pregnant. So you ask your OB-GYN colleague to prescribe a birth control pill. Suddenly you have blocked this system at multiple points, perhaps explaining now a higher risk for hyperkalemia. And then lastly, anything that blocks the sodium movement into the cell, you'll abolish that negative charge and impair K secretion, things like amiloride, triamterene, the antibiotic Bactrim, the trimethoprim component at least, and pentamidine, an older antimicrobial. Well, what are the clinical consequences of hyperkalemia? Again, one of the things that's been noted is that on a chronic basis and based on epidemiologic data, it seems to be associated with higher mortality. This is one of several papers in the literature to suggest that higher baseline potassium values are associated with higher mortality. And for any given value, the greater number of risk factors you have seem to augment that risk. Once again, whether or not it's hyperkalemia per se that's driving the mortality or the underlying disease state, is an arguable point. But nevertheless, the relationship seems to be reproduced in several studies. Cardiac toxicity is always something we think about. I'll just share a clinical example of this. This was an individual that we had seen. In fact, my colleague who's has the office next door, Dr. Miguel Vasquez, who I think some of you have worked with. This was a young diabetic man who we put on an ACE inhibitor. And shortly thereafter, you can see he started developing, he developed weakness. And when we got an EKG, you can already see the prolongation in the QRS interval. And, we decided, we had read about these EKG changes, but we said, why don't we just kind of sit on this and see what happens? And all of a sudden, now we didn't really do that, but it quickly evolved into a sine wave pattern. And then with calcium to stabilize the cardiac membrane, some D50 and insulin, you can quickly normalize back to where you were. Muscle weakness, again, this particular patient did complain of weakness. I always tell our fellows, if you ever get asked to see a dialysis patient who's complaining of being weak, you always have to be suspicious of hyperkalemia. And the other thing I would point out is impaired acidification. Hyperkalemia, particularly in an outpatient setting, is often coexistent with a normal gap acidosis. And actually, the two are somewhat related. And I would just remind you of a current thinking as to how that might occur. So we know that hypokalemia and a low blood pH markedly upregulate ammoniogenesis. But on the other hand, hyperkalemia tends to decrease ammoniogenesis and limiting buffer availability for distal hydrogen ion secretion. Well, just to remind you, hypokalemia and low blood pH actually upregulate these two enzymes, as well as the transport processes that bring glutamine into the proximal tubular cell. And as a result of these enzymes being more active, you strip off the ammonia and deliver it into the tubular lumen for its subsequent export to serve as a buffer. I would point out that a byproduct of the complete metabolism of glutamine is formation of bicarbonate that exits the cell in an electrogenic fashion, coupled here to sodium. Okay, so this is what's going on in hypokalemia and metabolic acidosis. Why would hyperkalemia shut this off? Well, again, it's somewhat analogous to what I described in that distal nephron. With rises in extracellular K concentration, the gradient across the cell membrane is now going to be less. In other words, you're going to depolarize this cell. It will become less negative. And if the extrusion of bicarbonate is an electrogenic process driven by cell negativity, with the cell being less negative, there'll be less extrusion of bicarbonate. And in essence, you'll alkalinize this cell. And again, these are pH-sensitive enzymes. And so the process of ammoniogenesis could then be explained as to why it's decreased because of the hyperkalemia, cell depolarization through these K channels. Obviously, the other thing that impairs ammonia availability to serve as a buffer is this competition for its reabsorption across the thick ascending limb. Remember, potassium and ammonium have very similar ionic radii. They can actually substitute for one another. And so if you have lots of K in the interstitium, this may impair this transcellular K flux, where it ultimately serves as the buffer. So the point is, hyperkalemia impairs kidney acidification by limiting the buffer availability. So again, just to summarize to this point, remember that the kidney has a large ability to excrete K. The distal nephron has a capacity to register small changes in extracellular K excretion and initiate K excretion. There is evidence of a gastric kidney signaling that may initiate potassium secretion as early as K entry into the stomach. Hyperkalemia is unusual with GFRs less than 20 due to adaptations. But whenever you see early onset hyperkalemia, think about abnormalities in distal salt delivery, disturbances in the renin-angiotensin system, or intrinsic diseases of the distal nephron. Let me just say a couple of words about management. Again, if I see hyperkalemia, the first thing I like to do is go through the patient's medications and see if there are things that we might be able to modify, particularly NSAIDs, and always asking about over-the-counter NSAIDs. Dietary K counseling is something that we typically employ. Now, you've all seen these types of slides, the fruits and vegetables, for example, that are enriched in potassium. But my point here is I think we have to be nuanced in how we restrict diet, because the fruits and vegetables are obviously heart healthy. And to, in a blanket way, say, hey, just restrict all these fruits and vegetables, we're kind of giving up on potential cardiovascular benefits. So we need to be a little bit more nuanced in that. In fact, there is evidence that people who eat less fruits and vegetables may have faster progression of their CKD. In this study that looked at urinary K to creatinine ratios as kind of a marker of fruit and vegetable intake, notice that the people who had the highest amount of urinary K tend to have slower CKD progression as compared to those with lower amounts. So again, we're giving up on potentially beneficial effects when we just in a blanket way restrict these types of entities. So it's really kind of a catch-22. I would just point out, for example, to give you an idea, fruits and vegetables that have a lot of fiber, even though they may contain potassium, the bioavailability of that potassium is a lot less compared to fruits and vegetables with less fiber. A fruit and vegetable that has more carbohydrate content might stimulate insulin to a greater extent, shift K into cells, and be less offensive compared to fruits and vegetables with less carbohydrate. So I think with the help of our dietitians, we can be a little bit more nuanced in this regard. Good diuretic therapy, I think we all agree, is effective in limiting hyperkalemia. I always remind people, if you use furosemide in CKD management, make sure to use it twice daily. But again, increasing sodium delivery and flow will enhance K secretion. Correcting metabolic acidosis, if it's present, will have a favorable effect also on the management of hyperkalemia. We always bring up the idea of discontinuing or lowering the dose of renin angiotensin system blockers, which many of these people are on, but it's kind of the same story. That is a catch-22. Current guidelines suggest that we should be using maximally tolerated doses of these drugs because of their kidney and cardiovascular protective effects. So the real issue is, how can you do that and avoid or minimize hyperkalemia risk? And so one of the ways I think that we can help do that is with the widespread use of the SGLT2 inhibitors. It's clearly, there's now several studies in the literature showing that SGLT2 inhibitors seem to ameliorate the hyperkalemia that occurs when people are on renin angiotensin system blockade. This is just kind of an analysis of several of these SGLT2 trials. And here on the left-hand panel, if you looked on serious hyperkalemia as compared to a placebo, when you're on SGLT2 inhibitors, there's less development of these serious hyperkalemia, or as here measured time to first investigator reported hyperkalemia. Again, it seems to favor a beneficial effect of SGLT2 inhibitors. So as we use these drugs more, this will certainly help, I think, with the hyperkalemia. The other thing we can consider are the K-binding drugs. As you know, we have 3 that are currently available. The first one, K-exalate, I would just simply say that I don't think it's a viable strategy to use on a long-term basis because it's so poorly tolerated. But we have 2 newer agents that are effective and tolerated, patiromer and sodium zirconium cyclosilicate. The first one of these, patiromer, it's a calcium-based polymer. You take it by mouth and it binds potassium primarily in the colon. That's the way it was designed. You do have to separate it by 3 hours from other oral medications that it can bind to. It seems to be able to bind to metformin, ciprofloxacin, and L-thyroxine. About 5% of patients can get hypomagnesemia, so you do need to be aware of that if it's an issue in your patients. And it's never really been studied in people who had bowel disease. This is just kind of a pictorial of how the patiromer may be working. Remember, most of the dietary potassium that you ingest is largely reabsorbed in the small bowel through the process of solvent drag. But as you reach here, the colon, we have both passive and active potassium secretion. The passive is mediated by luminal electronegativity that drives K. And then we have these BK channels. And interestingly, in the last part of the colon, there's a little bit of potassium absorption that occurs through this HK ATPase. So if you have this calcium-based polymer coming in, as it binds potassium here, particularly in the colon, it will now favor the gradient for passive secretion. And as you continue to bind it, it'll limit any K left for this last terminal part of absorption. And so again, this binding of potassium and these enhancement of transport is thought to be why the plasma potassium falls. As I say, it does release calcium. Most of the calcium is bound to carbonate and phosphate and excreted into the stool, but there is a little bit of calcium that's absorbed systemically. And then lastly, it does bind a little bit of magnesium. About 5% or so of subjects get hypomagnesiemic. This is just one study by Bacris looking at the durability of effect. So in these type 2 diabetic patients who had hyperkalemia, you can see with the once daily Pathophysiology, you could manage the potassium. And I would point out that 100% of these subjects were on a renin-angiotensin system blocker, again, suggesting that the drug enabled the use of the RAS inhibitors. The other drugs, zirconium cyclosilicate, again, it's a crystalline structure, highly specific potassium. The only other thing it seems to bind to is ammonium. So again, it goes back to the idea that those ions are very similar in size. Again, you have to separate by 2 hours from other drugs. The idea here is it doesn't bind other drugs, but because it binds ammonium in the GI tract, it will raise the pH along the gastrointestinal lumen and potentially have effects on drugs that had pH-dependent absorptive processes. It does exchange potassium for sodium, so at higher doses, you can get a sodium load that has been described as causing edema in some patients. This just shows one study that led to this drug being approved. When it started, it's typically given 3 times per day, and you get a fairly rapid initial drop here within the first 1 hour. And by 48 hours, these patients in this particular study had control of the potassium. Spinowitz did a 1-year study analogous to what I showed you with the Pathophysiology, again, showing that you could control in a durable fashion the plasma potassium. About 2/3 of these people were on renin-angiotensin system blockade. Lastly, Steve Fishbane has looked at this in our dialysis patients. Again, I have 2 shifts of patients, and sometimes, you see this recurrent and persistent hyperkalemia. And this is something I've tried now several times, but you can see that when the zirconium was given on non-dialysis days, as compared to a standard of care, you could control these individuals who had this persistent pre-dialysis hyperkalemia. The interesting point here is there was no change in their interdialytic weight gain or blood pressure, suggesting that there was no problems with the sodium load that may have been given. I'll just conclude by making this one last observation. With the zirconium, it's been noted that you do get a slight increase in the plasma bicarbonate concentration. Now, remember, we kind of talked about this. If you control the potassium, presumably you might restore some of the ammoniogenesis and perhaps have better distal hydrogen ion secretion. That's at least one way you could explain this rise in the plasma bicarbonate concentration. It seems to be a little bit dose dependent. But there is another potential explanation as well, and that has, again, to do with binding ammonium in the GI tract. So again, both potassium and ammonium has very similar ionic radii. They're both known to be bound by the zirconium. Why is that important? Well, under normal circumstances, we have the urea cycle. In other words, ammonium and bicarbonate generate urea, but most of the urea is obviously excreted into the urine, with only a small amount being taken up by the GI tract, where it's broken down back into its components and then delivered back to the liver, a poor enterohepatic circulation. With CKD and progressive loss of kidney function, more and more of that urea gets delivered into the GI tract, and this enterohepatic circulation is probably augmented. So another potential way in which bicarb may rise with the zirconium, at least, is that it binds ammonium in the GI tract, leaving selectively more bicarbonate to be then returned back to the blood. So it may be a function of just controlling potassium and restoring ammoniogenesis, or perhaps this effect to bind ammonia within the GI tract, allowing now bicarbonate to be returned selectively. I've already gone over the main differences between these two drugs. I won't say anything more for time purposes. So let me just summarize by saying for hyperkalemia, I like to review and adjust medications, good use of diuretics, correct metabolic acidosis as the mainstay of therapy. Restriction of foods enriched in K is something we have to think about, but I would argue to do it in a more nuanced way. And to whatever extent we are able to maintain full dosing of renin-angiotensin system blockers, this is somewhat of a dilemma though. SGLT2 inhibitors may allow us or decrease the frequency of hyperkalemia. There's emerging data that that's the case. K-exolate, poorly tolerated drug, but these newer binding agents are effective and could potentially allow diet liberalization and even facilitate the use of renin-angiotensin system blockers. So again, I thank everybody for your attention, and I'll be happy to entertain any questions or comments.
Thank you, Dr. Palmer. Much appreciated, and of course, brought a crowd pleaser topic for nephrologists to our grand rounds. A few questions already in the chat. First, and feel free to turn on your mic if you prefer to those who put a question in. But first question from Dr. Himmelfarb. First, is there data on whether total body potassium is high or low in this population that tends to be malnourished with decreased body cell mass? And then also he's wondering about how much of the hyperkalemia is due to altered mitochondrial energetics that reduce total body sodium potassium ATPase activity.
Yes, so, if you look at some of the studies that have looked at that, and we're talking now primarily in dialysis patients, even when you have hyperkalemia, you might think, gee, their total body K content is high, but in fact, when it's actually been looked at, it's a little bit on the lower side. And people have attributed that to uremia-induced dysfunction of the sodium potassium ATPase. There's some older studies where you take red blood cells from a uremic patient, it's decreased activity, and then you put it into a serum and that's normal and it restores the activity. So despite the first thought that you'd have total body K overload, which may be present in some, actually total body K is measured in these skeletal muscle biopsies. Old studies tend to be a little bit on the lower side. So I do think there's impairment in the NAK ATPase that's impairing K uptake by the cell that is explaining a lot of the high plasma potassiums, particularly with advanced CKD. At least that's kind of my take on that, but that's an interesting observation.
Dr. Rivara?
Thanks so much, Dr. Palmer. Curious what your thoughts are. I think over the last couple of years, there's been a number of studies really challenging this sort of paradigm of dietary potassium intake really being linked to serum potassium and mortality, especially in dialysis patients. I'm just recalling the C. Jason paper from a couple of years ago from an Australian group. And I'm just wondering whether you think we should continue to invest in so much dietary potassium education, for example, for our dialysis patients.
Yeah, I mean, that's a great point. And I think that's exactly what's happened. I think there's becoming a kind of a paradigm shift. If you look at the older trials or studies that said there's higher risk for hyperkalemia in dialysis, they were studies in which people were given potassium chloride salts, and there the Ks really went high. But remember, when we talk about diet, we're talking about potassium in non-chloride salts, potassium citrate, all these other anions. And likely the bioavailability and the tendency to cause hyperkalemia is a lot less. That's what people, and I think that's what explains really a poor correlation when you look at dietary intake and it's linked to hyperkalemia. Again, I cited two things that are potential variables: the fiber content that limits bioavailability of the potassium, the carbohydrate content. So yeah, I think more and more, and you cited some recent papers that our approach to just limit K in the diet is really not that effective, and that we don't really need to do it as much. I mean, clearly, I think if somebody's drinking juices from a watermelon or a melon, those things are going to be reabsorbed quite readily. But things that are in fiber, I think, are a lot less. So I'm not a dietitian, but that's kind of my take on the literature.
Dr. Mrotra?
Biff, thank you for this fabulous talk. Maybe you address this. I just want to understand a bit, again, the theme about risk of hyperkalemia in people on dialysis, those that are anuric in face of ACE-ARB and spironolactone, things such as that. Because you showed the BK channels, are these mineralocorticoid receptor responsive, and blocking them causes hyperkalemia. I hope I'm clear in what I'm asking. Would love to hear your thoughts on that.
Yeah, I mean, we use a lot of ACE and ARBs in dialysis patients, and in general, people tolerate it quite well. But there are people who it has clearly been documented, you put an ACE or an ARB and it's temporarily related to much more hyperkalemia than what was present prior to administration of the drug. So some of that transport in the distal nephron is thought to be influenced by existing mineralocorticoids. So I think it's not everybody, but there are some people who particularly seem to be sensitive to interfering in the role that mineralocorticoids may have on colonic K excretion. It's not oftentimes talked about, but there was a study not too long, several years ago, looking at inhibiting that 11-beta hydroxysteroid dehydrogenase 2 in the GI tract. And in fact, it was found that it really helped ameliorate the hyperkalemia, again, suggesting there's a role of mineralocorticoids in the colon. You might look at that. It's an old KI paper, but nothing ever came about it. Using a glycerotinic acid type compound to inhibit that enzyme to enhance colonic K excretion.
Dr. Corella?
Thank you, Dr. Palmer, for excellent lecture. I have a couple of questions for you. I mean, as you mentioned, humans have been designed to conserve salt, and our paleo diet was high in K, and now because of this westernization of the diet with the high salt, low potassium, that has been associated with cardiovascular disease, CKD progression, and also autoimmune diseases. So 2 questions for you. How much of high K causing, decrease in blood pressure is a vasodilating effect on smooth muscles versus dephosphorylation of thiazide-sensitive channels via Wnt kinase and SPAC pathway? And number 2 question is, because now our diet is low in K, even though our plasma potassium may be normal, would that contribute to something like hypokalemic nephropathy and chronic tubular interstitial fibrosis causing CKD progression?
Yeah, so the first question regarding the blood pressure lowering effect of, for example, high K intake. Exactly which one dominates, I'm not sure. High K intake is, again, as I say, is thought to exert a thiazide diuretic effect. If you look at the data that's looked at that critically, the effect of high K intake to induce a natriuresis is more prominent if subjects are on a higher sodium intake as compared to a lower sodium intake. There's also some older data, interestingly, that it was more pronounced in people of African-American ancestry, the effect of high K intake. There may be, though, other things, as you allude to, that high K intake is doing, perhaps effects on the vascular tree. Nick Medias wrote a nice review, also citing some data that high K intake may have some effects to decrease sympathetic outflow through central mechanisms. So it does seem to be through mechanisms that are beyond just natriuresis. Your second point about if you're chronically ingesting a low K diet, I guess, and even though your plasma K is normal and you're not, would that in some way or another predisposed to kaleopenic nephropathy? I don't think so. I think you actually have to have a low plasma K for that to occur. but it's an interesting thought. But I think my short answer would be, I don't think that's a risk factor. I don't know of any data that low K intake per se is linked to CKD in the absence of frank hypokalemia. Yeah.
Dr. Hazley?
Hi, so along the lines of all these expensive potassium binders we're using, there was a paper last year in Jason showing that just treating constipation and CKD significantly reduced risk for hyperkalemia. And I was wondering if you think constipation in our dialysis and CKD patients is a significant cause of hyperkalemia and whether we all need to be more aggressive treating that.
No, I do. I think that's a great point. Zaba Kovetsky had a paper not too long ago looking at the VA database, and again showing that use of laxatives had a favorable effect, just routine laxatives on, and it was associated with less hyperkalemia. So,
Right.
Maybe it is something that we sometimes forget about, but I do think that you bring up a good point. Therapeutic option, yes.
Dr. DeBoer?
Thank you, Biff, for the great talk and great discussion. And I was very interested in this gut-kidney connection that you were talking about, maybe primed by Mike Granda's talk. And it strikes me there are lots of things that happen when we eat a meal. I think we have increased natriuresis. We get rid of more phosphate in the short term. GFR goes up a little bit, I think, to enable these things. There's a whole host of things that happen when we eat a meal. And are we learning any more about what mediates that gut-kidney connection? It seems like there's a big one that we don't understand, maybe therapeutic potential, I don't know. Is there anything more you can say about those mechanisms?
No, I can't. Exactly how, again, the rodent model that I really cited claimed that there was initiation of K excretion in the absence of mineralocorticoid and absence of plasma K. So what is the signal? Is it a neural signal? Is it a hormonal signal that we haven't yet identified? I don't know the answer to that, but I think it's certainly worthy of further investigation for sure. Yeah, so I don't know that I have any better answer for that.
That's a start. Thanks.
Yeah. I would make one other comment. People with regards to the diet, again, a third factor, I talked about fiber content, I talked about carbohydrate content. The other thing is alkali content. Remember, when the alkali content in fruits and vegetables, a higher pH in the tubular lumen actually opens up the ROM-K channel and facilitates K secretion. That ROM-K is sensitive to pH. And so again, one of the other things of alkalinity that might occur with fruits and vegetables would also enhance K secretion. Again, going back to the idea that there's such a poor correlation between diet and development of hyperkalemia in a dialysis patient or CKD patient.
Dr. Grobotkin?
Yes, thanks for helping us out with hyperkalemia. For years, we heard about the transtubular potassium gradient, and that was determined not to be accurate. So I have two questions about a non-renal versus a renal source. First is, could you comment on a 24-hour urine potassium and a spot urine potassium to creatinine to look for a renal or non-renal source? And I'm also wondering, since the kidney is so good at handling increased intake of potassium, other than those acute crush injuries or cell death, what are some common causes of hyperkalemia that's not due to the kidney? That would be a non-renal source that we might find.
Well, you ask a great question, and I'm not sure that there is one. And in fact, for that reason alone, people ask me, do you check urine chemistries in people with hyperkalemia to look for renal versus extrarenal? I'll be honest with you. I think for hyperkalemia, I don't find that urine chemistry analysis, whether it be 24-hour urine K-creatinine ratio, is all that much help. I think from the clinical setting, you can determine the cause of hyperkalemia, and it's almost always going to be some kidney problem other than those acute medical illnesses that you cite. Where I think there is a role for K-creatinine ratios, that's in the workup of hypokalemia. There's more causes of extrarenal causes of hypokalemia, whether it be cell shift, obviously gastrointestinal loss. But to be honest with you, virtually all cases of hyperkalemia are going to be kidney causes of one sort or another. Now, and even when you think about adrenal disease, mineralocorticoid deficiency, that's a kidney cause. The only role in the setting of a hyperkalemic subject where a K-creatinine ratio or even 24-hour urine might be of use is if you wanted to determine, following the initiation of a drug like Florinef, what kind of response am I getting? Is the urinary K-creatinine going up, suggesting intact responsiveness to the mineralocorticoid, or is there no change suggesting mineralocorticoid resistance? That's really the only role, in my opinion, of looking at these urine studies in a hyperkalemic subject, because virtually all these people have some kidney role or a hormone that's influencing the kidney.
Okay, that's very helpful. Thank you.
Well, thank you, Dr. Palmer. Clearly, a lot of interest in this topic. Much appreciated. And thanks to both of our speakers today. Excellent talks.
I just show my picture on the summit of Mount Rainier. I thought you might like that.
In a prominent position in your office, it looks like, at least for today.
That's where my mountaineering career started. Mount Rainier. I love that place. Yeah.
Happy to have you back anytime.
Okay. Thank you so much for your opportunity to speak to your group. Thank you.
Thank you, Dr. Palmer. Thank you, Dr. Granda.
Can I just ask one last question before we go?
Oh, sure. Go ahead, Justin. Dr. Palmer.
All right. Thanks again, echoing what everyone said. This is great. This talk. My question is all hyperkalemia the same? So is like iatrogenic hyperkalemia from like RAS inhibition, does it lead to the same amount of like arrhythmias, mortality, etc., with non sort of medication?
Yeah, it's an interesting question. I think the toxicity of hyperkalemia is likely the toxicity is the most important factor that dictates toxicity is the rate of rise, I would argue. So a rapidly rising from whatever cause is going to be more dangerous than a slow rising. Yeah, I think if you have hyperkalemia in the setting of heart failure, again, perhaps it's more toxic, although to be honest with you, to ferret out that kind of information in literature, I don't think it's so obvious, but I would argue that hyperkalemia in the setting of a disease state like heart failure and the like is probably more dangerous, but clearly the rate of rise, is the big variable.
Thanks.
But that's, kind of a little bit of a hand wave, I have to admit.
Well, thank you again. Maybe a record in rapid fire physiology questions. So happy to have you. Everyone have a great weekend, and we'll see you next week.
Bye.
Thank you.